bone, skull, and outside of the dura, that would be epidural hematoma. And if the blood clot is underneath the dura and on top of the surface of the brain, which would be like pressing on the surface of the brain, then that would be subdural hematoma. So this is a subdural drain. This is a very common situation that we get in this hospital, subdural hematoma. And subdural hematoma could be of different, remember, if it's venous, we have time. If it's arterial, like the case that I'm going to show you, it's going to be emergency, big emergency. You have a few minutes to save this patient. Now, the blood in this subdural can be of different stages. Could be acute, we will be able to see and note that on the CT scan. Acute blood is the white signal, Then subacute is sort of like gray, gray, light white and all that. And then old or chronic subdural hematoma is just looks like CSF, a dark kind of fluid, on the CT scan. So you will see, when I see a CT, I know if this is a chronic subdural hematoma, it happened weeks and weeks ago. Is it subacute, happened 2 weeks ago, 3 weeks ago, or it's an acute, which has happened over the past 24, 48 hours, okay? So then, based on the size, we will, based on the thickness of the clot and how front to back it is, may need evacuation, and usually it doesn't get all fully evacuated. That's why we put a drain, and that's the one that goes to a bile bag and sits in the bed on the pillow without any need of any kind of suctioning or adjusting the head. So dural drain. Okay, so this is now the ventriculostomy catheter. That it's a catheter just like that. The scalp is open, the bone is drilled, the dura is opened, and this catheter is placed usually in the OR, but sometimes even at the bedside in ICU. Goes inside this cavity, which is the ventricle, which collects the CSF. Okay, and then this catheter is tunneled out of the scalp. Okay, and there's a dressing here. And then this goes and gets attached to a collection chamber, which I thought we have here, but we don't. Okay, there's a collection chamber, but I'll show you the pictures and go over that with you. In this case, when you have a ventriculostomy, this is a very important drain. Why? Because first, it's sitting inside the brain, so it should not be yanked or pulled or anything like that, especially during the transport to CT and all that. And secondly, you gotta note that it's sitting in and draining CSF, so how much it drains, you gotta note, is it according to the measure that you want per hour, or is it more, or is it less? It can get clogged, So the function of this is to drain the CSF and keep the pressure, intracranial pressure, to the normal level. Why? Because inside this fixed box, bony box, you have brain tissue, you have CSF, and you have blood, which is inside the blood vessels. Nothing else should be there. CSF, blood, brain, okay? So if there is something else, like a lesion, such a hematoma or a tumor, or edema, cerebral swelling, any of those would increase the pressure inside the head. The job of this catheter is to, one, measure the pressure inside the head. Second, as long as it's open, it will act upon that, If the pressure is high, and I'll go over all that, it drains, So not only it diagnoses the intracranial pressure, it treats it also automatically if it's high, and I'll show you. Now, in this one, on this side of the picture, what you have is called a Camino bolt. What this is a fiber optic. We don't have this here in this hospital. Usually this is used in the setting of trauma. And there's brain swelling, and you want to just know what the intracranial pressure is. They pop a Camino bolt. We put it, a little hole, twist drill hole, put the fiber optic, and it attaches to the monitor. It shows you the pressure, but it cannot treat it, This one shows you the pressure, and it can treat it by draining CSF. That's the fastest way to normalize ICP, intracranial pressure, is by draining CSF. That's a board question, okay? Mannitol, head up, hyperventilation, all of those are measures that decreases the pressure in the brain, ICP, the intracranial pressure. But the fastest, quickest, if a patient is herniating, you know, like the brain is exploding and pushing down, the fastest way is if you have a ventriculostomy, open the ventriculostomy, drain 10, 20 cc's. That's a life-saving. So Camino bolt ventriculostomy. Okay, so now here's what we go. So this ventriculostomy, this is the collection chamber, okay? This is just a collection bag. Now, first thing when this is, let's say, a patient that we are worried about the intracranial pressure. So first, we put this patient at about 30 degrees from the horizontal. Why is that? Because the volume of blood in the head at any moment is a function of the blood that gets pumped to the brain by the carotid arteries and the vertebral arteries versus the blood that gets drained out of the brain by the jugular veins, okay? So two set of arteries, two carotids and two vertebrals are taking blood inside the fixed bony box, and then two big veins, the jugular veins, where you put the central lines, take it out, okay? So when the head is down, more blood gets to the head, and because it doesn't have to act against gravity. So it's a good supply for arterial oxygenated blood, but then it increases the volume of the blood at any moment inside the head. So if somebody has high pressure in the head, you don't want to increase the volume of the blood. When you sit up the patient, let's say vertically, you are minimizing the arterial blood going up because it's acting against the gravity, but it's a very good way of draining all the blood down, you know. But it's a compromised situation. Why? Because you want arterial blood to go and give oxygen to the brain tissue. At the same time, you want it to drain pretty good so it doesn't accumulate in the head and increase even the pressure more. So this 30 degrees measurements have shown that this 30 degrees is the Goldilocks, that it doesn't compromise the delivery of arterial oxygenated blood to the brain. At the same time, is a good, you know, point that drains enough of venous blood so the head doesn't swallow. Okay? So the first step is having the 30 degree. So that's the first thing you do. You look, measure. There's a measurement on the bed that the head is 30 degree. And the neck is not kinked like that because it may kink the jugular veins. So the neck is nice and straight, and the back of the head is 30 degrees. That's the first thing. Then, this is the measure of 0 point for this chamber, okay? The catheter from the ventriculostomy, this part goes to the ventricle, this gets tunneled out, there's a dressing here, comes out, okay? Comes out here, and then gets, when this is the 0 of the measuring chamber, okay? This 0 should be at the ear level. And once you put this at the ear level, you can assume that 0, which is showing here, is the same as the baseline intracranial pressure inside the head. Then, this pressure chamber, as you see, it can roll up and down against that 0, okay? So if this is 0, and then you put this pressure chamber, you take it out, let's say you put it to 20, let's say this is 20, okay? As long as all of these connections are open, what it means is this, that if the pressure inside the head goes above 20, let it drain. So if it's 22, 25, 26, it will drain. But if the pressure inside the head, ICP, intracranial pressure, is less than 20, let's say 17, 11, 9, then it won't drain. So this will do the job. Now let's say the order says keep the ventriculostomy 10 centimeter above the ear, or keep the ventriculostomy 20 cc or 15 centimeter above the ear, which means you just adjust this and there's a knob, okay? You tighten it, so this level of the arrow is at this. This shows you the height above the head. This is 0, okay? And this arrow will show you the level that you are. So if this is 20 and I want it to be at 10, that means you bring this down and tighten it. So anytime the pressure above inside the head is above 10, it will automatically drain fluid to lower down the pressure. Remember what I just said? The pressure draining is the fastest way of lowering CSF, okay? Now, keep in mind, you have to be careful making sure that all of these stopcocks are open. Why? Because if this is closed, even if the pressure inside it is 100, it's not gonna drain. Okay? So you gotta be always vigilant of all the things that can go wrong inadvertently. So you make sure if there's any stopcock here, there, wherever, that they're all open, so the pressure inside the head and the pressure inside this chamber can equilibrate together, okay? So that's why. So the first thing you do is make sure the head of the bed is appropriate, neck is not kinked. Then you come, bring this, attach it at the horizontal level of the ear. So if this is the 0 in this chamber, that would be the baseline of the pressure, like 0 in the head. Then according to so this is the ruler. Then according to the next thing is this chamber. It gets attached, this arrow here, at different levels. If I say keep this open at 0, then you bring this and put it here. And I said put it at 5 centimeter, put it there, meaning it means if the pressure is higher than 5 in the head, let it drain. That's what you're telling this system. 10, 15, 20, usually. ICP, normal ICP should be between 10 to 20. That's the normal. If it's less, fine. But you don't want to be more than 20 for too long, okay? And then, let's say, and then here's the stopcock here. Let's say for 1 hour, this is, we have placed it at 20 cc and it's been open, allowed to drain, and it's draining, let's say it drained, let's say 18 cc's, for example, okay, over 1 hour. This, you close this in order to collect, so you can document how much it drained during that 1 hour. How many cc? Was it 5 cc? Was it 12 cc? Was it 18 cc? Okay? And then once you measure it, you open this, allow this to just collect in the collection bag, and you close it again, keeping it ready for the following hour. See how much more in the following hour it drains, you know, at this current parameter. You document, okay? From 10 p.m. to 11 p.m., drain 12 cc, okay? So you just, for one instant, open to empty this, to give more room again, but then you collect it again. If you leave this open, it keeps draining, going there. You're not gonna be able to measure at the end of the hour, well, how much was, you know, there. Any questions about that?
I would just like to add with ventriculostomy, especially ICU, you have to be extremely careful because you're going to do a lot of traveling, you're going to be on a CT and things like that, and you really need to watch and make sure that that drain is level, because when you're moving a patient and you lower the head.
Well, let me make a point about this. During the time of patient is in ICU, this is a sort of a stable setup, okay? If you have to make a trip to CT and come back, obviously this cannot be maintained like that. So what I usually do from a practical point of view, let's say patient going for a CT, I say, stop this stopcock here, okay? Take this off, this pole, put it next to the patient's head, go. So for the few minutes that you're going for the CT and all that, it's okay. But what you don't want is this, for this to be hooked and then transferring the patient and this gets yanked and pulled out, you know? That you don't want. So stop the stopcock, put it next to the patient's pillow bed, transfer the whole patient, go do the CT transfer, and then come back. When it comes back, you go again. Start with the head position, number 1. Number 2, put this to the pole. Number 3, put the zero of it at the level of the ear. Then number 4,